now I'll just introduce Anne. She's the Scientific Manager for Born Ontario. Has a long history of involvement in perinatal care initiatives. She has a PhD from the University of Alberta and currently has a joint appointment with the University of Ottawa as an adjunct professor. She's done research and published in the areas of fetal surveillance, preterm birth, low birth weight, bed rest in pregnancy, and the second stage of labor. So I'd like now to welcome Anne.
Thank you. Thanks, everybody, for joining. I see there's still people coming on, and so hopefully as we go along in the presentation, I won't have lost too many, and hopefully people will be able to get on as we continue. So in terms of the presentation, I'm just switching slides now. Not switching. Sorry, just a little technical issue here. There we go. Okay. So the presentation today will be an explanation of Born Ontario for those of you who aren't familiar with the group. Talk a little bit about our data holdings and where we are now and where we'll be in the future. Talk a little bit about data access, the process for getting data. We'll talk a little bit, and really why I think I was invited here today through this group is we're going to talk about the process of data de-identification and the benefit that has both for researchers and for Born Ontario and for people who hold research data. And certainly we'll talk about expectations regarding the use of data in a research context. So who are we? We're Born Ontario, and you can see the picture here. Born acronym stands for Better Outcomes Registry and Network. We used to be called the Ontario Perinatal Surveillance System, and some of you will know us from back then. But we're now a more formalized network, and as we go through, that'll be clear. So the vision for us is the best possible beginnings for lifelong health. And so Born works with both the policy people, the research committee, so the policy people in Ontario who help to set policy around maternal-child health, researchers who are answering important questions by using the Born data, and some of the perinatal networks in the province who help the policy people roll out any initiatives, as well as work with Born on quality assurance projects based on the data. The founding members for Born Ontario came together, and we'll talk about why in a minute, but you can see listed here are the groups that are currently actively working together to build a new database of maternal-child health indicators in Ontario. And that is the Fetal Alert Network, and those are the people who collect information on congenital anomalies and help and care for women going through the process of dealing with the diagnosis of a congenital anomaly, and the coordinators that work with them. The maternal multiple marker screening, which is the prenatal screening information in Ontario. Newborn Screening Ontario, who looks after, obviously, the screening of newborns after birth. The NIDA perinatal databases, and those include both the birth information and the NICU modules. And in that group, we also have a group of coordinators that are help their clients and hospitals around the province with that information. And the Ontario Midwifery Program, who maintain data on midwifery care in Ontario, prenatal, birth, and postnatal care. So those are groups that are currently working together, and those are the groups that then form the new Born Ontario. So the rationale for why these groups are working together and why we receive funding from the Ministry of Health and Long-Term Care to bring together and to make Born Ontario come to life is because all of these places have rich sources of information for clinical care and surveillance that Born can leverage. And the reason we brought all these together is really for the purpose of facilitating and improving the provision of health care. You can see these listed. Providing high-quality data that supports both evidence-based decisions, health planning, and management and evaluation within the health system. Eliminate redundancies. You can imagine that these 5 groups starting out, and many more places who are collecting data, do collect a lot of the same data. So to eliminate redundancies and enhance efficiency, it seemed wise to bring these groups together. To mandate and maintain data standards. obviously, one of the key things is to improve linkages between data holdings, and I'll talk a little bit more about that later. But the idea by being able to look at women throughout the continuum of care, or the babies and children, or by encounters within the healthcare system, we need to have the ability to link records across those data holdings. We want to analyze utilization of services to identify individuals who have not been offered the services available, and we'll talk more about that in relationship especially to newborn screening, and supporting research and innovation. So this is really the rationale why Born Ontario was formed and funded. There's a couple questions on the that are showing up here. Whether you need a headset or cannot hear anything. You should have to dial into the conference call if you want to be able to hear via phone. So I think there's probably some people who are working on that now, but that's just a quick answer to that question. The current state of the data that we have in Born Ontario, you can see listed across here: first trimester, second trimester, third trimester, birth, and the postnatal area. And the data sets that we currently have do span this continuum of care. And that's where we're starting from, is really knowing a little bit more about the pregnancy, the birth, and the early postnatal period. So Born is a registry under PHIPA in Ontario, and Born, when we were currently OPSS, was granted registry status in November of 2009. And registry status affords Born Ontario the ability to collect, use, and disclose personal health information without consent for the purposes of facilitating or improving the provision of health care. And that without consent is a big responsibility for us in ensuring that hospitals who are collecting data and outpatient areas that are collecting data certainly know that there are responsibilities and privileges associated with that. Somehow it doesn't seem feasible to get consent from every woman and every child in the province for their data to be used. So therefore, you are allowed to collect it without consent, but there are tremendous responsibilities that go along with that in terms of how it's disclosed. So this special authority requires Born to develop and adhere to rigorous privacy policies and have them reviewed and approved by the Ontario Information and Privacy Commissioner. And Born Ontario is in the process of submitting all those policies at the current time. So the current state of where we are with the project is that there's 5 separate data systems that need to be integrated. And we had a rigorous RFP process, and Dapasoft is the vendor that was chosen to help us bring these groups together and to make a more consolidated data system that those of you who are researchers will appreciate. We are using a phased, focused approach to developing this new data system, and our major areas are on linking and matching to get the ability to look at women across encounters and certainly throughout a continuum of care, making sure that the data definitions are good between all of those groups, that we know what the reporting requirements are, that we're taking into account certainly privacy and security, and then of course there's a huge change management process. So the growth and development of Born should mirror the growth and development of babies that are in the Born system. And our goal really will be to tell the story of the birth cohorts in Ontario. And you can see the pictures I put in here are from the time of birth, and in fact, if we had a fetus in utero there, that would be a better picture to start with. But the time of birth, young children to older children, and eventually as we go forward. So you can see in this particular arrow the data sets that Born will be talking to find out how we can get better pictures across the province, because all of these groups collect various pieces of data that would improve the story of what happens for women and families as they go through pregnancy, birth, and into the childhood period. So some of these in the middle of the arrow we currently have. Other people we're talking to find out what kind of data they have, how in fact we could work together to improve that story for Ontario families. So the current Born data sets, this is really for those of you who are researchers and who are wanting to know exactly what is available. The NIDA perinatal database and NICU modules have been around for quite a while. It was an iterative process so that it started slowly and grew across the province. right now, the best data set that we have is a very clean 6-year database of hospital births. Now, there is data before the 6 years, but certainly the best cleaned and verified database is 6-year one, and we add to that every year. So about 140,000 births. We have 100% capture now in the perinatal database at the end of 2009, and slightly less each year before that. You can see back in 2004, I think we had about 82% of the province, and that's been a very concerted effort on behalf of the people who worked for the Ontario Perinatal Surveillance System and the hospitals in the province and midwifery practices in participating in that, because it really has taken a lot of effort to grow that, and it's a great accomplishment for the province of Ontario. This database contains information on the maternal health history, the pregnancy, the birth, and the early postpartum period. For the NICU module, we have about 33 of 45 NICUs participating in data entry for the NICU module, and we are actively working on integration plans for others, and certainly there is a committee looking at that right now. I think what's most important for researchers to understand is that the data is collected and entered by healthcare providers and not abstractors. So when people ask us, you know, you could really have about 54 more data elements on different things, that is true. However, what we've tried to do, because healthcare providers take time from their busy practices and busy work life to enter this data, is to make it data that's going to be valid and reliable, and they don't have to dig a ton to get. So I think that's important for us to remember as we go forward. There is very little identifying information available for linking in the NIDA system. We don't have any names or OHIP numbers yet, so any matching that we're doing with other, or linking with other groups right now is done on probabilistic matching. We did do a recent data quality audit on the NIDA system, and that publication is underway now, so we'll have some stuff to report on that soon. So that's the NIDA perinatal database and NICU module. The Ontario Midwifery Program database has not yet migrated to BORN. We're in the process of working out all the details for that, but we can help facilitate data cuts and analysis as needed. It also has hospital and home births where midwives were in attendance, including prenatal and postnatal care. Many of the same variables as in NIDA, so it's good to be able to look across care providers. And just to give you a perspective, midwives are primary care providers in home and hospital for about 6 to 8% of births in Ontario. The Fetal Alert Network database is the congenital anomaly group in Ontario, and they capture information on women whose babies are diagnosed with congenital anomalies during pregnancy and are referred to the FAN program for care. And in the FAN program, they help steward the care of those women throughout the various specialty appointments that they require, and help them make important decisions about the fetus and newborn. About 1 to 3% of the births in the province would have a touch point with FAN. Obviously, there's a lot more congenital anomalies that we're not capturing, and BORN is working with FAN and other groups to develop a strategy for better surveillance of postnatal anomalies and better capture of prenatal anomalies in Ontario. Newborn Screening Ontario has data on all babies screened shortly after birth for about 28 rare disorders. I think I have the number right. The data currently resides at Newborn Screening Ontario, and we're in the process of working out the process for bringing that data over. And it could be part of a data request. Almost 100% of babies in Ontario are screened, and they collect information on a little bit about the pregnancy and birth, and then certainly around time of screening and that sort of thing. With the newborn system that we're building, the data will come via feed and be linked to the prenatal and birth data for those women and babies. For prenatal screening, that data currently resides outside BORN, but it could be part of a data request as well. Again, we're just in the very midst of bringing all these things together and working on the linking and matching algorithms. Data on all women who choose to have prenatal screening in Ontario and the outcomes associated with that are available. There are 5 labs and 18 genetic centers that provide input into that. And to give you perspective, about 65% of women in Ontario choose to be screened or are offered screening. We're still working on finding out the answers to that. And again, with the newborn database, that data will come in via feed and go through the linking and matching algorithms to be properly attributed to the right people. So that's sort of the outline of the BORN system and the data that we currently hold in-house and those that we can access for assistance. So the types of requests that BORN gets for data include what I would call aggregate simple requests, aggregate complex requests, record-level data, so researchers who want to have record-level data and manipulate it to answer important questions. And then we get requests to do analysis in-house and provide researchers with the answers to their questions. So simple questions that you can see listed here, and how many births in Ontario last year, and then to get a little bit more complex, how many nulliparous women had primary and repeat cesarean sections by Lynn region, so we can cut data different ways. What proportion of women had prenatal screening, how many missed newborn screens in live births, those sorts of things. Those are pretty aggregate, simple questions that we answer. And to answer those requests, those don't all have to come to BORN Ontario, what we would call the central office. The individuals within the data contributing organizations do have access and can compare themselves within their regions. There are BORN Ontario regional coordinators that can run some data for their regions if they're having trouble, or can facilitate access for people in hospitals who don't currently have access to the BORN system who want it. Obviously, we kind of keep track of who has access and for the amount of time they're going to need it, and we ask for permission from directors or chiefs of departments as to who can have access in their own system, because it is their data. And there are some rights and responsibilities that go along with being able to access the BORN system. The BORN regional coordinators can be found on the BORN website, which is bornontario.ca. And if you don't know who your BORN regional coordinator is, it would be a good opportunity to meet those people and find out what they can do to assist you with any of your data needs. The new reporting software that will be available in the new BORN build will make reporting from the BORN system much easier and will have much more depth for analysis. So those simple aggregate questions are not a problem for people to do on their own if they have access to the system, or for BORN regional coordinators to help them with those types of things. More complex aggregate data requests are things like where people might want to know the rates of smoking in pregnancy in Ontario by education, by income quintile, by neighborhoods, and we have the ability to link the BORN system to the PCCF, the Postal Code Conversion File Plus, which links to census data to answer some of those questions, which would be a really good plug for me to tell you that if you haven't contacted your member of parliament or whoever about reducing the census information. For any of you who do research, I expect that you probably have put your plug in, but when they make that voluntary as opposed to mandatory, it's going to destroy a lot of important research data. So there's the plug for that. If you want specific perinatal outcomes by neighborhoods, running by postal codes, those are more complex aggregate data requests. And, depending on your research question and your REB approval and those sorts of things, we can certainly answer those types of questions. And we can do statistical testing for differences between regions and proportions and outcomes and that sort of thing. So we do have the ability to do that. That's still aggregate data, but more complex requests. And accessing data for research, and I'll go into more of the record-level data in a minute, but there is a data request form on the BORN Ontario website, which you can see there. And currently, it just lists the data elements for NIDA right now, but it will be expanding with the new build when we currently figure out each of the data elements and how to get a form that's going to work. In the new data system for BORN, there's going to be over 600 data elements. So it's a bit unwieldy right now to think about putting together a data request form for that. But there will be over 600 data elements, and some of those underneath those initial data elements will have huge number of choices. So, for example, when you think about newborn screening and all the analytes they use, and same thing with prenatal screening, it could potentially be quite huge numbers of data elements. So we're just trying to work on a way now to figure out the best way to do that. We do have a new data dictionary in process, and that will be very helpful for researchers so that you'll be able to figure out exactly what that data element is that you're asking for and look at the definition online for that. And for your information, I think I need to tell you, for researchers, it is the BORN policy that we provide data in the least identifiable form possible, and we have policies regarding small cell sizes and small denominators. And so I'm going to go into that in just a minute. So in terms of record-level data for research, which is what a lot of people, I would imagine, are wanting to know, is how they get their hands on data at the record level to be able to manipulate in some sort of statistical software package to do research. And you can see these are just some of the data request questions that we've looked at in the last year. And these are just, particular questions that people are working on. So, and a lot of people would also want to know a little bit about the costs for born data. And we do have an implementation of a new policy for record-level data access or complex aggregate data requests. We have a flat rate fee or an hourly fee depending on the complexity of that. We're just putting that in place now for the people who got in really early. They got the freebies, but it obviously becomes important for the amount of work that we're doing for researchers to be able to attach a fee to that to recover our costs. We will try as much as possible for graduate students to exempt them from fees if it's for their own projects and not their supervisor's team project. So again, all of this is still underway, relatively new, but we're working on that. And as I mentioned, BORN will do analysis based on researcher specifications and only present them with aggregate data on request. So the BORN decision-making process is what you see here in terms of that request. So when a researcher goes on the website, grabs the data request form and says, here's my research question, here's the data elements I think I need to answer that question, we have this sort of algorithm that's listed here. And what you can see here, the first step is when that comes into our office, we look at it and say, is this project feasible? Is it scientifically appropriate? And are the data elements relevant and necessary? And that's done internally right now in BORN. And if there's, questions, we certainly go back to the researcher. If there's a big problem with the research question, we'll talk to the researcher about that and suggest modifications or that sort of thing. But if everything seems to be in order, then we'll move on and consider the request. The difference is, of course, is it an aggregate data request or a record-level data request? And we'll follow down the left side first, which is the aggregate data request. And we obviously need to find out first, is the data actually aggregate? Could there be any potential that a person could identify someone from this data? So if you were asking for data from a small LIN in Northern Ontario and you wanted to know the number of congenital anomalies that were delivered in that LIN in the last, 1 year and how many babies had a gastroschisis, for example, or something like that, that potentially could be an issue because there may only be a very, very small amount of those. So, we look at those requests and figure out is that actually an aggregate request that wouldn't lend itself to potentially identifying someone. So, we look at those sorts of things and could there be any harm in that? And if there's no harm, then we, have a little bit of paperwork, and we talk about a date where we might be able to provide that. We talk about what it would cost to provide that data if there is a cost. We are responsible to report to the CHIO. Children's Hospital of Eastern Ontario is the lead for the BORN program, and the REB there oversees the BORN data set. And so we are responsible to report not only record-level data requests to them, but also all the aggregate data that we're providing. And so we, meaning the BORN Scientific Office, has to report to the REB. So, if there's no particular problems with the aggregate data request, we can go ahead and provide that. For record-level data requests, that's a little bit more complex, and this, I'm glad that Colette is here because he may be able to help us with some of the questions if we have this. But we work very closely with Dr. Colette Elamon, who we just heard from, who started the session, in the Electronic Health Information Laboratory at CHIO, and they're world experts in privacy and finding ways about de-identification of data sets. So this is the group we work with. When we get a record-level data request and the research question is clear and everything's okay and we're set to think about providing data to this group, we send it over to this group here at the Children's Hospital of Eastern Ontario for a review. And that review, which I'll show you in just a minute, they look at the items that are identified in right now, the NIDA perinatal data set, and they look at the data items that are potentially identifiable or very, what's the word I'm looking for? They're risk, or that they're sensitive is the word I guess I'm looking for. Some of the maternal health issues are sensitive data. And so they look at these data elements in combination with one another and provide us with a risk of re-identification. And they use a tool called PARAT, which I'll show you in just a minute. So when we get that record level data request, we work with the group here at CHIO, and we provide for the researcher an objective measurement of what the risk is. And we have a threshold for what we will give out in terms of risk. So there are two parts to this. Even though the researcher has gone through REB approval generally in their own center, the CHIO REB group here also has to approve it because they are the custodian of the born data. So most of the time it's an expedited review because it's a secondary data set. That's not the right word I want. What is it, Colette? It's a secondary use of data. Thank you. And so there are two parts. One, the REB at CHIO, and one, the process that we go through here with the eHIL, Electronic Health Information Laboratory. So the process we go through is iterative. The researcher asks for the data elements they want, and the group here, as I mentioned, uses the PARAT tool to assess the risk of re-identification. And if the risk is above the threshold, we go back to the researcher and ask them to modify their request. Now, Coled's group has lots of experience in figuring out what the risks are. And when you have heard him talk, things that you think would never be identifiable by looking at a data set, and most researchers believe that they're not going to have any risk of re-identification based on their data elements. I mean, how could knowing somebody's birth weight and somebody's, sex and somebody's, I'm trying to think of another variable that we use, cause any risk of re-identification? But in fact, when you hear Colette talk and hear some of the stories and some of the ways that data has been used to re-identify people, you know you want to have the most stringent precautions you can. So the PARAT tool is the Privacy Analytics Re-Identification Risk Assessment tool, and it looks at potentially identifiable variables in combination with one another and determines the risks and suggests ways to reduce the risk and or suppress a certain percentage of the data to reduce the risk. And the example in the born NIDA database is that our areas that are potentially identified variables are maternal date of birth, maternal postal code, maternal health problems, maternal aboriginal status, and baby date of birth, baby weight, baby sex, and congenital anomalies are our really sensitive ones that we are concerned about. And so their algorithm looks at what the researcher requests, whether you request all of these, some of these, or whatever, and their algorithm defines whether or not that's a particular risk when those things are combined together. And the picture I have here and I put a little box at the bottom that you can then go on to their website and learn about these terms because it's not real clear at the beginning. But you can see what this researcher has asked for is maternal date of birth by year, baby's date of birth by unchanged. That means they want the exact date of birth, they want the gender, and they want the birth weight. And when they use their assessment, when the risk comes out at 98.8% of those records are at risk. And Colette, could you just give the brief update of what prosecutor risk means?
Yes, so it means that if you imagine the nosy neighbor, with that information, a nosy neighbor who gets access to the data set would almost, with certainty, figure out which record belongs to that mother, if they had those 4 pieces of information as background information.
Okay, and there's a more detailed explanation of all these types of risk on that website that's listed there. So the threshold is 0.1, and you can see here that by the researcher asking for those 4 things, that's the risk. And so obviously that's not acceptable. So then we go back to the researcher, and Colette, when they run this analysis here, they provide some alternates that the researcher might want to consider. And so the next slide that I'm putting up now is an alternate suggestion. And you can see now the difference is still asking for maternal date of birth in year, but have changed to ask or to think that baby date of birth, instead of having the exact date of birth, would be month and year of birth, and gender and birth weight unchanged. And so that brings the risk down. You can see we're down to 8.29% of records at risk that would need to be suppressed if that was the choice. However, to reduce the risk even further, you can see here now, by reducing maternal date of birth and getting it in ranges of intervals of 5, so, you know, if the mother was 20 to 24 and 25 to 29 or that sort of thing, having the baby date of birth in month a year and gender and birth weight the same, now the records were really low. We're down to 2.whatever%. And in this case, this researcher decided they could accept a 2.2% suppression of their records. So when they've agreed and we've all happy and it's gone through REB and everybody's okay with that, then the data set will be generated with a random suppression of 2.269% of the records in that database. And so that's sort of the way the process works. And I'm just looking at a question here. If the risk is above the threshold, does the researcher also have the option to attain, it says X, but then it was cut off, so I'm just trying to see here. Obtain express consent if possible. If the risk is above the threshold, does the researcher also have the option to obtain express consent if possible? That would be very, very difficult for us, almost impossible. So I would think that the answer to that question would be no. And if you're working with that small a sample that you can get express consent for whatever it is you're doing, you may be looking at a different option than going through BORN to get your data, I would think. Okay, so I hope that process is kind of clear. So the advantages for researchers, I think by using this method, you can have access to data elements that are previously unavailable to you or severely limited. So in a lot of places where you go for data, you know, when you ask for maternal date of birth or something, they're just going to say no. And in this case, we're offering you an option. You may not get maternal date of birth. You get maternal age at time of birth in intervals, which is better. And I think probably what this process has taught me and taught probably some of the researchers we've worked with is really it's important to think about your research question and your implications up front. In that you don't need, most people just go through the data thing and say, yeah, I need this, 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 and this. And they kind of are on a fishing expedition and thinking about what they might do with the data afterwards, where we're kind of forcing this way to think up front about how you could do your analysis and, you know, what is really important for you to have in terms of, in terms of the data. I think there's also reduced risk among your own team members for any re-identification, and you should feel quite confident in this process that you are really going to get, as best as possible, a de-identified data set. For BORN Ontario, it reduces our risk of any inadvertent re-identifications in terms of providing data for research. It helps us meet best practices for data management. And I think for both groups, but for BORN and for researchers, it's a very objective way for making decisions about data. The actual risk identified is you'll see it. It's not just somebody saying, no, you can't have that. There's a risk to it, and that risk is identified and is available to you so that you can see the process. The disadvantages, of course, is because it's an iterative process, it can be a bit time-consuming by the time we go back and forth 2 or 3 times. However, BORN Ontario is fairly new. We're working stringently to try and prevent this by working with researchers up front to prevent them asking for everything and being realistic about timelines and what BORN will be able to provide for them. So as I go through in this process, I've been learning a lot, and I'm now able to very confidently talk to researchers about their questions and the type of data elements and talk to them about what I know we won't provide and what you know, is our best practices. Now, people can always make arguments for asking for more specific levels of data, and you know, if you really need something to answer your research question, we'll try and work with you the best way we can, but we do have limitations as well to meet our requirements as a registry under PHIPA. So So the future, I think for BORN, we really look forward to working with you to answer your important maternal-child research questions. We look forward to working with you in terms of being able to meet your data requirements. And I think the future is bright for maternal-child research in Ontario and having these data sets. The ability with the new data system to have this linked data set to look at women across a continuum or children and to, or else to be able to look at encounters within the healthcare system, I think is a very promising future for us all. I've put up some email addresses here, and I'm going to look now to the questions that are on the screen to see if we can answer any of those questions. So if you do have questions, you can go to the screen on your desktop and fire them in. The first question from Angelique is, what sort of relationship, if any, does BORN have with CIHI and the Ministry of Health and Long-Term Care? Does BORN provide access data to non-health care provider entities such as government agencies? So BORN has a very active relationship with the Ministry of Health and Long-Term Care. They're our funders, and we certainly provide data to them, aggregated data. If they were doing research, they'd have to go through the process like anybody else, but we certainly have a very active relationship with them. With CIHI, the discharge abstract database that CIHI maintains that has a lot of information in it is somewhat different. So all the hospitals are contributing data to CIHI and BORN a little differently. CIHI data is done by abstractors, whereas I mentioned BORN data is done by care providers. And the second question was, does BORN provide access data to non-healthcare provider entities, such as other government agencies? Yes, we work with, we entertain data requests from everybody, and we have a long list of people that we're providing data to. Most people are in healthcare, but we've had some requests from other non-healthcare agencies. And the next question was, with data requests approved, can you publish results? Yes. As long as you have appropriate REB approval, you can certainly, with data requests approved, can you publish results? I'm thinking hopefully that means you've gotten data from BORN Ontario and you're going to publish a study. And as long as you have the appropriate REB and we have the appropriate assurances that you're using your data appropriately and you've done everything correctly, there's no problem. In our data sharing agreements that we draw up with researchers who have record level data, there are some specific requirements about how that data is to be used, and those just have to be met. So certainly we are thrilled if people will publish data from BORN. The question was, how do public health units access BORN data for the purposes of evidence-informed public health practice? That's a really great question. We are working with a group in Ontario now of representatives from public health, both from the Association of Public Health Epidemiologists and from public health units across the province to sort out public health unit access to BORN data. We realize that data is extremely important for public health purposes. We're just working out the logistics of the difference between health information custodians and what we can provide to the public health units. We have a paper that the public health units have provided to us in terms of what they need, and we're currently just in the process of reading that paper and responding to them. So there will be some access, certainly, for public health people. Question was, if we currently access NIDA data, will we need to reapply to be able to use BORN? No. If you're, well, it depends. If you're a hospital person, then, your access to BORN is there. If you're a public health person, then, as I just mentioned, we're sorting out that access to BORN, and that will become clear in the next little while. Will analysis be, the next question is, will analysis be at the health unit level? Analysis can be at the health unit level in the BORN data system. When we receive a data set, we map that to public health regions and to LINs. So we can certainly do analysis at the health unit level. And in fact, if you look on the BORN Ontario website under bornontario.ca, under reports in the upper right-hand column, you will see a series of reports that we have just done on maternal-child health outcomes for the province of Ontario by health unit region, and there's also a summary set of slides there in PowerPoint for some of the indicators aggregated to the provincial level. Are there preconception indicators included on existing or future databases that will be combined into BORN? As I mentioned, we are looking at other data sources and how to include those into BORN in the future, and certainly preconception health would be an important area that we would be looking at. So the answer is yes, but it's not in the immediate state. It will be future state for where we're going. Can you explain healthcare provider? Who are you referring to? I would, in terms of people who are entering data, it tends to be nurses and other people in hospitals who are entering the data. So there's some nurses, there are some people who use clerks, there are some people who use their decision support people. I don't think there's any physicians entering data currently. The next question is, what level of bias in data estimates was resulted from BORN's de-identification process? Yeah, you can answer that.
Okay. So this is Khaled. The amount of suppression, so the bias would only come because of suppression, and based on the experience over the last year or so, the amount of suppression has tended to be quite small. I think in almost all cases less than 5% and less than 1% in the majority of those. And with that level of suppression, it's quite easy to impute the missing values to reduce the amount of bias. So the amount of suppression that's put in there is quite small that it wouldn't have any practical impact on bias. And in terms of statistical power, the suppressions have really no impact on statistical power. Generally speaking, for most tests, you reach 90% power at around 3,000, 4,000 observations, and with the BORN data set, you have hundreds of thousands of observations. So it shouldn't have an impact on that either.
The next question was from Wendy. We contact NSO almost daily with phone calls and faxes about newborn screening results, repeats, etc. Will BORN be able to provide us access to newborn screening records to eliminate this back and forth calling, or will NSO be? So the clinical part that you're doing with NSO will remain with NSO in terms of that. The newborn screening results that are coming into BORN will really be for the research purposes. So anything clinical that you do with NSO will continue to be with NSO. There's a question about, are there any public health representatives within your organizational structure? There are important population health assessment questions, not just research questions with the potential to be addressed by BORN. Yes, we have a member, we have a public health epidemiologist on our scientific working group for BORN, and we are actively working with public health groups in the province to find out what it is we can do to help public health units with data access. Next question was, do you envision health units going through the data request process? As I mentioned earlier, sorry to keep repeating this, we are working actively with public health now. The process isn't defined. For any research request, yes, a health unit would have to go through the same process. For just day-to-day access to data, as I mentioned, we're working on that with public health groups now. Question was, how does BORN support individual requests to have their PHI excluded from BORN or contributing systems? So if an individual wants to know or have their personal health information excluded from BORN, that would be something that would go through our privacy group. And I'm sorry, I don't know the answer to your question. I do know that if somebody wants to know if their personal health information is in BORN, they can contact BORN through privacy@bornontario.ca, and we will provide an answer to their healthcare provider. And they can go back through their healthcare provider to find out the answers to that. But if I haven't answered your question appropriately, then you can email privacy@bornontario.ca and somebody will get back to you. Will BORN Ontario be able to capture births from Ontario mothers that occur in another province? Right now, no, we can't do that. In the future state, it would be really nice to be able to go to Manitoba, certainly where I know there's births from Northern Ontario that certainly go over there as their tertiary care referral center in some places. And for women that actually have to go to the States or end up in another province. But right now, it's a small number. I know they're important, but for right now, that's not part of our scope, but we are looking at it in the future. There's a question about, will there be LIN reports available soon? We are working on those in Bourne. The template is done almost for the largest LIN regions, and it's out for review now, part of it, and we're working as hard as we can to get those done. So in the meantime, if you have a specific data request that you need to know, you can either contact your Bourne regional rep, or you can contact us, and we'll see what we can do to help you. Are there any other questions? Okay, well, if there are no other questions, I think we went through everything. Then just check, make sure there's no more that we've missed here. No. Okay. So if there are no other questions, I'd like to thank you all for attending, and I'd like to thank the Electronic Health Information Laboratory here who invited me to do this webinar today. In terms of getting a copy of this presentation, I think Colette mentioned at the beginning that it will be available on their website. Give them 24 to 48 hours to get it up, the recording done, and the slides and everything will be there, so you can go and access that from their website.
And everybody who's registered will receive an email with the link for where to go, so you should expect to see that in the next day or so.
Yeah. And I hope that this has been informative for those of you who are doing research and want to be able to learn a little bit more about the data that we have in the Bourne system.